I'm hoping that in the next few months it might welcome you back to Northgate. And I've got feedback, so if anybody's got their microphone on, could they switch it off, because that might help. I'll try. Right, I think that's better. Somebody's responsible out there somewhere. I'm really hoping that in the next few months we might be able to welcome you all back to Northgate, because although we're getting quite good at this and I can see a lot of you on the big screen, it's nowhere near the same as being able to meet together. But anyway, welcome. We've got a very busy day and a busy agenda, so I'm going to plunge straight in. And George, can I ask you if we have any apologies for absence?
I haven't received any, Sheila.
Okay, thank you. Could I go to declarations of interest? Do I have any declarations of interest other than the normal? Well, I have one I should make. We have a presentation as part of Jeremy's report on some work that's coming more into play in the western part of the county, although it's been active in the east, the One Clinical Community. And I am an associate of Oliver and Co, who have been delivering that programme. I have no pecuniary interest and I haven't done any work in West Suffolk area since I arrived at West Suffolk. But I think it's right that that should be put on record. So after that, I have 3 questions from members of the public. I have a question from Joe, which is on air pollution, and it outlines the fact it's a serious health issue and has a national import. So for each of us, our health is unavoidably shaped by the environment we live in. Environmental factors determine about 30% of our healthy life expectancy. Air pollution poses the single greatest environmental threat to human health. And we know that breathing dirty air is associated with a host of health problems, from asthma to cardiovascular disease and lung cancer. And all too often, it's the most vulnerable, children, older people, and those from poorer backgrounds, who are hardest hit. So, clean air helps us live longer. I think it's a wonderful issue for Joe to bring today, because it's Kate's quarterly report on integration and on the alliance working, on the way that we are moving to work in a system-based way. And it seems to me that the answers, if there are answers, or the mitigations, the directions of travel in this particular topic are very much ones where we need to work together. We deal with the end result. The system can actually impact further back and have a real impact on pollution. But we have our part to play as well. So Kate, could you pick that up within your report?
Yes, Sheila, happy to.
And a very practical question from Florence, which is around endoscopy. And we know that it pretty much ceased at one stage because of COVID. And it's really vital to the recovery. And if you look at the statistics on page 55 and 56 of Convene, the figures for all 3 types of procedure began to recover last month, but they've dropped to very low levels in comparison with the prior 4-week average, and also in comparison to other hospitals. And Florence is seeking, quite rightly, to be assured that the reasons for this are both understood and are being addressed. And Helen, I think that's going to come up in your report, isn't it? And some of
Sheila, happy to cover that.
Thank you. And the last one, Jeremy, which lands in your court, is an appraisal one. And it is understandable that appraisals will have been difficult to carry out when dealing with COVID. However, on page 74 of Convene, appraisal figures have historically moved slowly upwards, which is good. Appraisal is a vital part of professional development. Can we be assured that checks are made to ensure there is not a consistent avoidance by the same members of staff, and that there is not a set of pattern of no appraisals by certain areas within the hospital? And Jeremy, I'll add an extra one. Sorry to be awkward, but I do think, and I know you're committed to this, the quality of appraisals is hugely important as well. Sometimes in the past, high achievers have achieved a lot of ticks, but not a lot of substance. So if you could pick that up in your report, Jeremy, I think you'd be delighted to, wouldn't you?
Absolutely.
In which case, I would like to move to our guests. We have some of the team that have experienced the One Clinical community work, and I felt that as we got Kate's integration report, and this has proved a very useful vehicle for some of the learning, and the East have adopted it widely. It's very much being picked up by the University of Suffolk and their Integrated Care Academy. I'm going to ask Kate just to say a few words, and then we'll hand over to the people who've actually experienced this way of working. So, thank you, Kate.
Thank you, Sheila. So I was frantically multitasking to make sure Amanda, who's coming to talk, has got the invitation. I think she's got it now. So
I have introduced everybody because I can't see them on screen at the moment, so I'm hoping they're in the room.
So the One Clinical community actually was born out of a conversation with Paul Molyneux, Sue Deakin, and some of our GPs when I very first joined West Suffolk, when we were talking about what was missing and what would make a massive difference in our clinical leadership model. And it was building up the networks that used to exist, and for some reason, for various changes in the NHS's structure, didn't have the impact that they used to. So bringing clinicians together across the patch in a leadership to have leadership development, to work on a common problem, was kind of where we settled as a way forward. And you're right, the East launched the year before we did in terms of the programme, but we followed with a slightly different lens on it, looking at how we got the clinicians and broader than that, social care colleagues and district and borough colleagues together in a locality footprint, which we've talked about before, getting them working together on some of the key issues in their area. And I think it's fair to say it was a huge success, and we've built on that for this year and looked a little bit deeper into the one team approach, which is part of what underpinned last year and has been expanded on this year. And then Jeremy and I are working on the next iteration really of the One Clinical community element of that, which will be much more centred around some of our common challenges at the moment with and opportunities with the Future System programme and what the white paper has put in front of us in terms of an opportunity for change. So we're working that up at the moment, but the one team element of that begins in June. So it'll be lovely to hear. I think we've got Andy and Amanda, haven't we? Unless Jeremy wants to add anything to that.
No, yeah, I'm a bit concerned that we don't have everybody with us actually at the moment, Kate. Oh, Andy's there. He's just arrived.
So I can talk about this at length, but I don't think it's me you want to hear from.
Good morning. Can I welcome Andrew Dunn, and who else have we got, Kate?
We've got Amanda from Suffolk County Council, or I've just sent her the invite, so she was just joining. Maybe start with Amanda and we can come to, sorry, Andy, and we can come to Amanda.
Okay, I'm going to leave you two to organise yourselves because I'm sure you've had a pre-conversation. I'm going to hand over to you because I know that you've got clinical time to go to this morning, Andrew. So thank you very, very much for giving up the time to be here.
Okay, pleasure. So I'm going to try and, oops, sorry, I'm not turn my camera off, but share my screen. Just bear with me a second. So while Andrew's doing that, I think it's probably worth just highlighting the fact that the orthopaedic team, and Andrew's a brilliant orthopaedic surgeon, has got once again delivered some of the best hip fracture care in the country, and we should pass on our thanks to both Andrew and team and colleagues while you just get things up, Andrew. Can we also say congratulations, Andrew, because you're going to lead some of the regional work on orthopaedics with Tim Briggs, and that's a great accolade for you and a great testament to your leadership on orthopaedics as well, Andrew. Okay, thanks, Steve. It's very kind.
Thank you, Steve, for picking that up. How are we doing on the sharing, Andrew? Ah, we're there.
I can't.
It's loading.
Okay.
It's come up, Andrew.
So I can't. My screen is blank.
Now we can see your, we
All
can
right.
actually see your first slide.
Now. Right, great. So thanks for the invitation. So I'm obviously here to talk about the West Suffolk Alliance One Clinical Community Leadership Programme, which, yeah, for me was an epiphany. It is absolutely, you know, fantastic, you know, programme that I would fully recommend you continue to support. Yeah, I'm just so feel very privileged to have had the opportunity to take part in it. Yeah, it was, yeah, it's made a massive, you know, difference to me as an individual, and hopefully to the people that I work with. So what did I learn? First of all, self-awareness. So I'd never done anything like Myers-Briggs before, and when you do that with Judy and the team, and you find out a bit more about yourself, and it certainly enabled me to understand why I'd maybe reacted and behaved in certain situations, and I think as a leader, having good self-awareness is really, really important. It taught me the importance of, you know, listening to all, you know, staff and patients, the importance of giving people good attention, and also, you know, gratitude. It improved my understanding of the NHS system that we work in, which is both, you know, complicated and complex. And again, emphasised the importance of collaboration with colleagues across the whole system, so in community, adult social care and primary care, but with the best interests of patients. We should be putting the patients at the centre of everything that we you know, do. And also, you realise in secondary care that you're very protected, and the challenges that your colleagues, our community matrons, you know, our adult social care colleagues and our colleagues in primary care face are, you know, considerable, and you know, that's not to be sort of you know, underestimated, because otherwise there's a tendency to kind of work in, you know, silos, and I would say pretty much all the other participants, you know, were very sort of inspirational, and it was a, you know, pleasure to, you know, meet them all and work, you know, with them. And then how have I applied what I've learned? Well, it gave me the confidence to take on the role that I played for the organisation during the coronavirus pandemic. It's helped me build relationships within the hospital with people that I hadn't really met before or worked with before. It's given me the confidence not to avoid, you know, difficult, you know, conversations, and also I think highlighted the importance of, you know, being authentic as a leader, and not just, you know, walking the walk, but actually about talking the talk, and particularly when, you know, we're working towards improving our culture, with regards to being compassionate leaders, with regards to the conversations we're having around civility and psychological safety. I think that's really, really important. And finally, again, just wanted to say thank you to Judy and her amazing, you know, team. Speakers like Ian McShane, Toby Young from Southend, and the sort of I can't remember the lady who organised the Fearless Speaking session, but yeah, the program's been absolutely, you know, brilliant, real epiphany for me. And I don't think, in all honesty, as Steve has already mentioned, I had an interview for the improvement orthopaedic lead for NHS England, NHS improvement for the East of England last Monday, and was successfully appointed to that. That's a role I'll be sharing with Julian Owen, who's another consultant orthopaedic surgeon from Edinburgh, and it's going to be challenging, but, you know, very exciting. And I don't think I would have achieved that if it hadn't been for you know, Judy and the opportunity that I had to take part in One Clinical Community. So I'm really grateful for that. And that's the end of my presentation. So I'll stop sharing if I can.
Thank you very much indeed, Andrew, and thank you for sharing that. And I thought one of the things you highlighted was we go on many courses, all of us, many developmental opportunities, but sometimes they don't lead to tangible outcomes. And I'm really pleased that you tied it to the impact it's had on you. Welcome, Amanda. I think you were part of the same experience. Is there anything you want to add?
I've just joined the call, so I'm not sure what I've missed so far. So apologies if I do repeat anything Andrew's already said. So yes, I did also have the privilege to be part of the West Alliance One Clinical Community program last year, or it was 2019, wasn't it? And ending 2020. It was great. I was really quite pleased to be part of it. It was very soon after I joined my role at the time as social work team manager, and just being around all the different professionals that we wouldn't ordinarily. So, for example, I probably wouldn't ordinarily have met Andrew in any capacity without having been on the program or had the opportunity to collaborate and to view the world from the same lens, so to speak, and to just really the emphasis on the fact that we're all there to meet a common goal, and all the different experiences we had there. I haven't actually asked how much time I've got to sort of talk about this. Couple of minutes?
A couple of minutes would be fine.
Yeah. Okay, so I think for me what stood out the most was just being given the time and space to understand each other's unique pressures, to demystify our respective realities, and like I already said, that we're all working towards a common purpose. I left with an overriding sense of optimism and a desire to keep the momentum going. We were obviously cut short by COVID. We were working on multiple projects that we were hoping to see to fruition. So my group was working on coming up with some kind of MDT process where we would speak about people with rising risk in the community, how best to prevent, reduce and delay the need for additional care and all of that sort of stuff. And we are in a position where some of that has been realized in different ways. So we are able to apply some of our learning in different ways. I am still working really closely with some of the clinical directors in my new role. I'm working very closely with Mark Hunter, for example. I've been on different other projects, for example, the vaccination inequalities group, and because I've met these other professionals, I was then able to draw upon their involvement. I asked Mark Hunter to be part of that, and it's working quite well. So just the networking, I think, is quite a big bonus, but also understanding more about myself as an individual. So the Myers-Briggs, for example, was really interesting, and initially I didn't quite identify with the result I got, which was ENTJ, and I thought, really? I didn't realize I was extroverted. But the more I thought about it and the more I introspected, I thought, of course I am. In a way, here I am talking to you all. But so some of those opportunities were fantastic, just to understand yourself better, how you interact with others, how you collaborate as part of a team, how best to produce the best outcome on behalf of people within the way that you interact with other people. I think that was one of the best things. And going to Southwold as well was fantastic, and meeting some really inspirational professionals at Adnams who spoke to us about just various things. So I didn't obviously hear what Andrew said, so apologies if I've repeated anything there, but I think it's a great opportunity, and I'm glad to see that this is being rolled out again in the form of one team, and I'm hoping that I am going to go back again to refresh on my knowledge on certain things. So and I know other people who are going are very excited to be part of the programme.
Thank you very much, Amanda. And I think, although you may not have heard all Andrew said, I think, what you've given us is the impact it made on you personally. But more importantly, I think it's, again, the tangible outcomes. It's about bringing something back from the experience that you can do something with, and how it fits. And Andrew, you alluded to culture, how it fits to the change in the way we approach things, and that comes back to us behaving differently in the end. And this obviously has that impact. Shelley, I'm aware you're in the room.
I am, yeah.
Is there anything you want to add? I'm not sure if you heard Andrew, but I believe you were there for all of Amanda.
Yes, no, I'd spoken to Andrew also. When I started the One Clinical Community, I was a community matron managing a caseload for long-term conditions, and it was really quite daunting from that perspective to be in the room with all these consultants and GPs, but you were soon made to feel in place and to feel valuable as being able to contribute to the same conversations, really. These sessions I found were excellent, and I like the fact that we all had, as Andrew alluded to, we all had the same sort of problems and conflicts within our roles, and it was able to make you look of this is what we need and how to get there. And I think she called it as the promised land, and it gave us ways of working out how we could be together, work collaboratively to get to that point. Personally, it helped me, you wouldn't believe it this time, with speaking formally, confidence in my profession and networking, and it made I was lucky to be at Sudbury, where we had social work colleagues together, and it really did enhance our joint working for MDTs, patient outcomes, and working with the GPs in Sudbury. And it has really made me self-aware of how I can make a difference and work together with other professionals properly. It made me aware of the NHS. We all have the same problems. But yeah, it was definitely a benefit, and I have recommended it to people if they could possibly get on it. I would really recommend it.
Thank you very much indeed, Shelley. I appreciate you coming. In fact, I appreciate you all coming. Are there any questions from the board? I think it's for me, it's the context of, we've talked a great deal about what we are trying to do, and I think it's important as a board over the next few months we look at some of the tangibles, some of the things that people feel are making a visible and real difference. I've got Jeremy and Steve.
Thanks, Sheila. I mean, for me, it's just another reminder of how important multi-professional leadership development is. So bringing different professional groups together. There is no other employer in the UK that has such a professionally diverse workforce, and each one of those has their own cultures and priorities. But bringing people together, promoting that level of team working and understanding between professions is what really makes a difference. So that really stands out to me, having listened to that feedback. Just to expand a little bit more on what Kate said around what we're exploring for the future. Of course, the thing that is so important right now is around our future system development, and we have many individuals in our organisation who are involved in the strategy and the planning of our future system, and it's really important not only that they are supported to get on with that work, but that they also feel supported and developed. So we think that the learning from the One Clinical Community approach could be really beneficial over the next few years as we continue to support the professional development of those involved in the Future System programme. And that's one of the angles that we're going to come at as we take this work further forward.
Thank you, Jeremy. Steve?
So I think those are fantastic presentations. It just underscores to me the importance of our leadership programmes to help us deal and confront with the many challenges that we face as a system going forward, also to underpin changes in culture. I had the privilege of a session with Andrew and colleagues who had gone on from West Suffolk on the One Clinical Community programme, and we had a conversation about what they gained personally from the programme, how they'd applied it, what more we could do to build on the foundations that have been established, and I think we need to, take a look at our leadership programs, make sure that they are aligned, fit for purpose for where we're going. I think certainly very, very supportive of the extension of the one clinical community, the team approach, because I think it's really come to the fore, both multidisciplinary and collaboration across organisations. That's at the core of what we need to do. We had a board session with Ed Garrett, the Chief Operating Officer from the CCG, and with the governors earlier in the week, and it's clear that very much the strategic direction is around collaboration. So a better understanding of the system and the constraints that we all face, but also really knocking down the barriers that exist between organisations. And the best way to do that is to build relationships and networks. So I think it's a phenomenal programme, and there's phenomenal feedback that we're hearing today. I think, Amanda, you mentioned the trip to Adnams. So we've got on Andrew's recommendation, we are going to hear from Karen Hester on the 20th of July at the next 5 o'clock club. And I think some of hopefully the lessons that were talked about and discussed from the one clinical community we can share with the wider leadership community at West Suffolk. And I'm sure that hopefully you all will be invited to that, and maybe possibly even introduce and chair that session. So I think that's fantastic. But I think it's a great example of how we are investing in leadership for the future to confront the challenges of the future, which will be working across organisations and in a multidisciplinary way. So it's really great stuff, and thank you for taking the time to present to us today. Really appreciate it.
Thank you very much, Steve, and you've summed up beautifully for me. And I would like to spend more time discussing this, but I'm conscious we have a busy agenda before us. Andrew, can I thank you for coming? Amanda, Shelley, can I thank you very, very much? Thank you for bringing the tangible outputs of what you learned, and giving us a sense of how that's making a difference, because that's what it's about. As I say, this isn't a course you do, you get excited about at the time, but nothing happens from it afterwards. And it seemed to me that it fitted so well with Kate's quarterly report on the integration, on the alliance working, because actually that isn't as easy as it sounds. We're all committed to it in theory. Making it happen is about people, it's about relationships. And this is the kind of thing which creates those building blocks. So thank you very much indeed for giving up your valuable time to be here. And thanks from the rest of the board on behalf of the board.
Thank you.
Thank you.
Thank you very much.
Opportunity. Thanks very much, everyone.
Thank you. Lovely to see
Take
you.
care.
Thank
Bye.
you. Right, rather inappropriate to the review of the agenda, and I've already done it. So my apologies for going off piece, but I was conscious that Mr. Dunn had a clinic this morning, and that's rather, I was going to say more important than board, but certainly equally as important. So I have no other alterations to make to the agenda. Can we move to the minutes of the previous meeting, please? And I am sure you will have marked those up. I can just come back to them, and I will take them page by page because they are quite extensive. Page 1, 2, 3, 4, 5, 6, 7. Angus.
I confess I'm a page beyond the page you've just called, so I'm on page 8, Sheena. I'm trying to make sure I got my hand up in time.
Page 8, which paragraph?
It was just a small point. I noticed on the record of our discussions about staff members who've been nominated for putting your first awards. I wondered whether we should actually name them in the minutes.
I think that's an excellent idea. It's a way of tangibly acknowledging. Yes. Could we do that, please, Jeremy? And Richard in future. Okay, thank you. Page 9. Angus, is your hand still up, or that's all right? Page 10, 11, 12. 13. Okay, thank you. Thank you all very much. Could we then move to matters arising, please, the action sheet? Right, if we start on the first sheet, the next one is due to come to board in May, and that's the one around community metrics. Alan, I think you raised this. Was there anything you wanted to query? Are you happy that that's on, that self-explanatory?
I'm fine that the team are working on it and just looking forward to seeing it. So no rush. Thank you.
Thank you. And the next item, which is due to report in June, which is the Keeping in Touch service. Any questions or comments on that, or are you happy with the explanation? I'll take that as yes, as there's no hands up. And the final item on that first sheet is on the agenda for today, so I don't think anybody will want to raise anything now. The next one is the information team head of performance, the SPC charts. That's due to report in May. Any questions or comments? Anybody wish to pick up? I'll take that as no. And the second one is June. That's the commencement of the deputy head of midwifery. Nothing, no questions. I see Sue nodding, so we'll take that as okay. And the next one is the SPC charts coming up again in July. Happy with the explanation there. And the final one is the quality of training provided in the 6 months education report, which is October. Can I just ask, Jeremy, that seems a long way off.
I think that's the date of when the next 6 monthly report is due.
Oh, that's all right.
I think that's why it's set then.
That's fine. It seemed quite a long way on the matters arising sheet, but of course I should have thought of that. And if we move to the next page, page 28 of convene, they're all complete items, unless anybody has anything burning about those or is not happy with the completeness. I'll take it as read. Okay, thank you. If we could then move to Chief Exec's report, Steve. We've read it, but I'm sure you'll want to pull out a few highlights.
Sorry, Sheila, there's the patient story first, I think.
Oh, my apologies. I slipped over that because there wasn't an attachment. Sue, are you leading on this one today?
Yes, I am. Yes, I've got.
My apologies, Sue.
I've invited Karen to join us to hear this story because it's relating to the maternity services we provided. So this is a letter.
Karen.
There's a letter. This is a letter from a grateful woman and her family or her partner, and she did share us some lovely photographs, but has requested these aren't shared in the general public. So I'll read the letter she wrote anyway. Dear Dr. Dunn, my husband and I felt compelled to write this letter after our recent experience at West Suffolk Hospital in November 2020. We attended the hospital on 21st of November 2020 when my waters broke at home and were heavily stained with meconium. We had planned and hoped for a natural home birth. However, the arrival of our beautiful baby boy could not have been further from this plan. We had been receiving excellent perinatal care throughout our pregnancy, including growth scans, as our pregnancy was a much longed for IVF pregnancy. Despite much change due to the COVID-19 pandemic, our care was very good. My labour was not without complication, even in the hospital setting, including a very traumatic birth resulting in an emergency caesarean section. This too was not straightforward, as the little boy was stuck and a code red was called and the consultant needed, along with some initial resuscitation to safely deliver our beautiful baby boy at 12:42 on the 22nd. Unfortunately, I too had complications from the anaesthetic, suffering from a complete epidural block with loss of consciousness and ability to breathe, and I too required resuscitation. As you can imagine, this was an incredibly scary process for both me and my poor husband, who was looking on in real fear of losing both his wife and child. Despite all the ups and downs of the process, I can safely say we both feel that we received the very best care. Staff went over and above and beyond to ensure we were fully informed, involved in decisions, cared for and safe. As a local GP who trained in West Suffolk, I know the hospital as a lovely, warm and friendly place to work, with everyone striving at all times to give the best care. However, being on the receiving end of care is a somewhat different experience. And as I'm sure you know, medics generally make terrible patients, so do nurses, to be fair, and I certainly do. However, At every point, I really felt I was in safe hands, even at the moment when I could feel myself struggling to breathe and keep my eyes open. I strangely but genuinely remember thinking, they, in brackets, the anaesthetic team, have this, they will see me through, which of course they did. My husband also assures me that in the 45 minutes plus alone with our baby, waiting to find out what was happening with me, he felt the midwives looked after him and the baby with the best care. The whole medical team, midwives, paediatricians, healthcare support workers, theatre assistants and anaesthetists, everyone carried out their jobs with great skill, but more importantly, with such a lovely personal human touch. The kindness, patience and diligent care that we received really did make what could have been a terrible experience just a little bump in the road. The people of your organisation really make all the difference and clearly love their jobs as they go above and beyond as basic standard. Sorry, I just need to go to the next page. I wish I could remember everyone's name to personally thank each and every one who has helped us, but with all that happened and the last few months with the baby, my memory is a little fuzzy. I do remember that both midwives, Trini and Kate, and their student were fantastic, so kind and caring as well as professional. Bex saw me in and out of theatre and helped clean me up and feel more human. After everything, her kind manner and humour really made the world of difference. Dr. Sinner and the two registrars gave me the greatest gift in the world, my healthy, beautiful baby, boy delivered safely. Kieran was the wonderful anaesthetic registrar whose calm professional manner, along with his warmth and humour, made a scary experience feel okay. He made me feel safe, even when I was in real danger. And his wonderful consultant, a lady who I'm sorry I can't remember her name, was so calm and professional. I felt calm, even when being resuscitated. They safely reunited with me with my son. I hope this letter finds Kieran, as I think the whole complication of resuscitation was a little traumatic for him also, and I'm sure despite carrying on and sorting it all out, he felt the pressure. He really did do very well. All three of us will be eternally grateful, not just for the team that did their job so well, but the manner in which they did their job. It really does make a difference. Every professional we met did the basics very well, including introducing themselves, debriefing us with us after events, providing us with easy to understand information to make the best decisions for our family. However, it was the smiles, the reassurance and the human touch they all showed, and the extra touches, in brackets, coming back to see me and the baby, checking in on us, cooing over him, will last in our memory. All of those we met genuinely are a great asset to your organisation. The postnatal care on the ward was also great. Again, very kind, caring and incredibly supportive. I felt really supported to breastfeed, and any questions, help and reassurance I needed was there on tap. I think that the postnatal midwife visit help has really contributed to me successfully exclusively breastfeeding my baby for the last 4 months and ongoing. I was initially very non-committal and apprehensive about breastfeeding, but it has been really lovely and important bonding experience, as well as the best for our baby's health. As a recent trainee and a medical professional, I know that it can be rare to get heartfelt thank you, and when you do get one, it does mean a lot. I also feel that when people have gone about their day-to-day job as if it's all just part of the course without realising just how exceptionally they are doing their jobs, they should be told. I hope this can be shared with everyone for their training portfolios, appraisals, etc. I would really like to extend our heartfelt thanks to you and the teams at West Suffolk for the amazing work you do. As a family, we will forever remember the care we received.
Thank you, Sue. And I think that reminds us of what we do really well. Karen, you must be very proud of your team. And I hope that the thanks have been passed on to all of them individually.
Yes, and I have shared that letter with them to all the team, including theatre, so everyone could get who could see it. So yeah.
It's the kind of thing that makes you remember what it's all about. And I have to say, I can speak highly of the maternity team, but it is about 40 years ago. So I don't think any of those midwives are probably still practicing now. But yes, I have to say, having a complication at West Suffolk even 40 years ago wasn't too bad an experience. So, but thank you for reading that, Sue. I don't know if there's any questions, but for me, it does remind us that we can do, we do some things exceptionally well. And that it isn't just about what you do. It's not a tick list. It's not just what you do, it's how you do it. We are human beings treating human beings, and we must never forget that. And the humanity is what makes the difference. So thank you for that. Steve?
Well, it's a wonderful story. Really is humbling to hear, but I also just wanted to tie it into the feedback that we've had verbally from the CQC around the significant progress that Karen, Ravi, Michelle and the teams have been doing on maternity. We've had a huge focus as a board on maternity services, and there's a huge amount of effort gone in to try and make services safer, more responsive, and I think this story epitomises that. So just while you're on the call, big thank you, Karen, and please pass that on to the team. We await the report and we'll deal with what comes through the report, but the verbal feedback was strong and positive, so thank you.
Thank you, Karen. Thank you, Steve. Steve, you have the floor, so I'm going to let you carry straight on because I'm conscious we've had a really lovely start to the morning, but we've got a way to go, so we need to pick up the pace a little. So over to you, Steve.
Thank you, Sheila. So you'll have heard the news yesterday that Sir Simon Stevens is stepping down from the NHS after 3 Prime Ministers, a referendum and an exceptional pandemic. I think everyone would agree that the NHS has had a good pandemic, and the vaccination programme is truly world class. So I think we should record our thanks to Simon for his leadership. Also, locally, I do believe we've had a very strong and good pandemic, and that's in part been down to the leadership of both Helen, who has very much led our operational response, and Nick, who has both supported and led in that operational and clinical response to the pandemic, but also Nick has very much been part of the vaccination programme that we've rolled out locally and for health and care staff across Suffolk, and that's been a phenomenal programme that I think we've all experienced and seen firsthand how exceptional that's been organised. Both Helen and Nick will be stepping down. Helen will be retiring at the end of the year, and Nick will be stepping down at the end of May for personal reasons, but will remain in the organisation. But I think we should record our debt of thanks to both for their leadership through the pandemic and on the vaccination programme, and I'm sure we'll say more about them over the coming months, but I just wanted to acknowledge their significant contribution to the organisation. We also yesterday bid farewell to Ian Stutchbury, our estates manager. He retired after 41 years in the NHS and 33 at West Suffolk. I think we should, as a board, record our thanks to Ian. Ian also and the team played a significant part through the pandemic, which is not over, but ensuring that we've got both sufficient oxygen, that wasn't an issue through the pandemic, and we did lots to make sure that we had sufficient supplies, but also to make sure that we put in place appropriate infection prevention control procedures, as well as make sure that our housekeeping teams, which reported in to Ian, were supported and doing their bit around the pandemic. So we should record our thanks. We have 0 COVID patients in the trust at the moment, but we do know all the sites close, such as Ipswich, continue to have COVID present. So we're not out of the woods despite the significant progress. And what we're observing internationally in both India, in Nigeria, in Brazil, in the Philippines, all just underscores that we must not be complacent. Also, we are shall we say, an employer of an incredibly diverse workforce, and we have many colleagues who have families in places such as India. It's really, really important that we support and acknowledge them, especially when they are trying to communicate with family back home, and there's sometimes quite difficult scenarios that they are working through, and I've spoken to several members of our staff on that. So we must continue to support our staff through the pandemic. We're very much focused on recovery, and Helen will say a little bit about that. We're trying to get some additional resources into the system to help with recovery, but we're also trying to balance that across the need to give staff a little bit of time to recuperate from the pandemic. Finally, from me, this weekend we will start to see the new modular site ward G10 start to arrive on site. That's going to be a 24/7 operation from the 1st of May to the 10th of May. We've had great close collaborative working with the local police and with the local council, and we're communicating with local residents that we will try and be as sensitive as we can. It's a way of accelerating the bringing forward of that additional ward, that additional capacity to help with some of the structural considerations and put in some additional capacity. But I just wanted to put on record our debt of thanks for the close working relationships that we have with local public service partners. It's another example of good alliance working, and I personally have spoken with the Chief Constable Steve Dupe, and they've been incredibly accommodating. So we should pass on our thanks for that. Thank you, Sheila. I hope that was relatively quick, but a few things important to mention. Thank you.
Thank you, Steve. Yeah, I think there were some very important things to mention. And if any of you are local residents, there will be a bit of disruption over the next few days as the various large loads arrive on site. But hopefully it will be kept to a minimum, and it will be for a relatively short time. And the end result is we can still treat lots of our patients locally. So I think at the end of the day, most people will understand that. The one's understanding at 3 o'clock in the morning is not always the same as it is at, 6 o'clock in the evening. But I think we've done our absolute best. And Steve, thank you. You and the comms department have kept me very well up to date with the messages that have been going out. And I think, by warning people, by being open with people, we're far less likely to have any kickback. People basically want their local hospital to be providing the care that they need and their families need. So thank you for that. And you handed beautifully in with your integration and your allusion to the system to Kate, who is the next item with your integration update. And Kate, it's really great to have a very thorough integration update. I know we miss you from our board every month. But having an in-depth dive or a more in-depth dive, perhaps less frequently, may give us some richer material. And there's a lot in this report. So thank you for that. Kate, do you want to say something before I introduce it? I suspect most of it's self-explanatory, and I've got some questions coming up already. Alan, is it on Kate's report, or was it on the end of Steve's just before we start?
Thank you. I've had a question. We jumped over Nick's vaccination report. And a quick question on that, please.
Yes, go ahead.
Okay. Nick, thank you for the write-up. Is there any early indication yet that we will have to reproduce this approach to vaccination on our site in the autumn? Are we being asked as an organisation to host this possibly again?
Not yet, Alan, but it wouldn't surprise me in the least. Probably with about 48 hours. No, I'm sure we'll get more notice than that. But it's definitely, we've been mothballed rather than wrapped up. I think it's very clear that there may still be a role for hospital hubs in the vaccine programme. It's just not exactly clear what yet. As you know, we're still delivering a little bit of vaccine to people in special circumstances. But I think it's quite likely that in the way that we manage the flu vaccine programme for our own staff, we will probably be managing the COVID vaccine programme for our own staff, but I don't have any detail on that at all yet that I can share.
Thank you, Nick.
So we might do it in the same way. We might do it in the same way, or might do it a bit different. We'll see how it develops.
I think it's a wait and see.
Right,
yeah, okay.
Okay, in which case I do now pass to you, Kate. Having introduced you, I won't do it again.
Okay, thank you, Sheila. And it has been strange not coming every month, and I've been quite looking forward to today. I feel I need to apologise for the 10 pages of paper, and I'm not going to go through them at length because they've been much trailed, and we've touched on a couple of pieces already. If I start with Joe's question, and Joe, I loved your question because I've recently met with the Integrated Care System's new sustainability lead, who is a ball of energy on this topic. And I got quite overexcited about the art of the possible in terms of doing the integrated piece and joining up the various pots of pockets of work that we've brilliant work that's going on the kind of sustainability and carbon footprint and emissions part of the ask at the moment. And we have Jill Corwin, who is one of the directors in our district and borough. She chairs the Suffolk wide board, which is only, I think, recently sort of started to kick in, to look at everything that underpinned in your question in terms of from understanding where we've got gaps and understanding how the various pieces of work that we're doing, looking at our environmental impact of services and what that impact has on health and well-being, actually is joining up and helping us to understand what we need to commission and do differently to kind of close the gaps. It's quite early on in those conversations. There's an enormous amount of work done, but your question sort of hinged around the kind of integrated piece. So I'm very happy to, when we're in full, I've got a little bit of a better picture for the West Suffolk footprint to bring something back as part of one of these reports. If that answers your question or helps, Joe. So I'll leave that there.
Joe, do come back to me if you feel that you want more substance.
Oh, there's a little bit of substance there, but I can get you some more in the longer term.
Thank you, Beth.
That's fine.
Okay, so the pieces that I wanted to pull out of the report are fantastic, really. So starting off with our partnership, which was born out of crisis, if we're being absolutely honest, going through our pandemic put an enormous pressure on our voluntary sector organisations, and as a consequence, we ended up with being incredibly fortunate and being able to use quite a lot of the staff that had been furloughed from our local leisure provider, actually is hands and boots on the ground element of the support to our communities. They did everything from running equipment stores to supporting our integrated neighbourhood teams to using their space in an innovative way. They were a key part of our system-wide response. And as part of that, we started some brilliant conversations looking at a vertically integrated model with Craig and his team about and Helena Joplin leading the charge from a clinical capacity. What could we do differently with them as a provider in terms of looking at the broader health and well-being offer to our patients? Because I think we're all very well versed in the impact of that exercise, diet, and social contact has in terms of people's outcomes and sort of broader well-being. And so we started some conversations internally and had a fantastic response from the consultants looking at if we partnered with Abbeycroft Leisure, what could we do differently? And what you've got in the pack, which I won't go into massive detail on, but is the objectives that we kind of signed up to, which gives us a foundation looking at different pathways for individuals around prevention and rehabilitation and how we prepare people for their acute intervention as well as their recovery period. And then what we've done is we've already set in train several exercise by referral and kind of broader wraparound offers of support for our population. So that's the detail of that's in the paper, but I think the piece from a board perspective that it gives us is another string to our bow and a partner that actually has a infinitely flexible model that we can look at in terms of lots of different pathways. I had a conversation this week around cancer and looking at, I don't know if any of you have heard of the cancer boot camps, looking at what we can do around exercise at the beginning, the middle and the end for our cancer patients, just to help them deal with their journey, both socially as well as kind of mental health perspective and also impacting on their outcomes and recovery. So I think we're at the beginning of the journey, but what we've proved, I think, or beginning to prove, is the concept. And I think the thing that struck me has been the energy that it has sparked in the kind of broader system piece with people who, when they hear about the work that's being undertaken, they're very keen to be involved. And that's therefore giving life to other elements of integration with other parts of the voluntary sector and our district and borough colleagues, again with Abbeycroft Leisure. So it's a fantastic news story. Additional roles in primary care. This probably sounds like it's a little bit of a dry cracker, but in reality, the piece of policy that came down to look at actually how do we get more a more diverse workforce within primary care, and the various sort of pots of funding and policy, which is at times has been difficult to kind of translate into operational reality, has been grabbed brilliantly by our primary care networks. There's a little bit of a basic table in 2.8, but it just gives you a feel for some of the additional staff that we've now got operating within our localities and within primary care to help to give a more rounded offer to our population, but also help the clinical model to develop and to give a much needed capacity, but additional capacity in primary care, but also allowing us to kind of tie in to our other elements of our integrated neighbourhood teams. So we have mental health practitioners, our social prescribers, our OTs. Again, we're early on the journey, but I think it has made a material difference, and I think it will go on to as well. And Sue and I had a conversation earlier in the week about looking at what we're doing as a system around supporting our nurses in the non-hospital settings. We've obviously got a strong leadership in the community sector, but from a primary care perspective, we've run networks, we've run education days, but there's probably more development that we can look into, and that's something that we're talking about doing together, which would be exciting. And then the other piece that we've sort of trailed already was around our vaccination programme, and I'm not going to rehearse the hospital element of it, but I think it's probably been quite well publicised. We have had a fantastic response, and at one point we were leading nationally in terms of our percentage of our population vaccinated, and that has been an absolute credit to the whole system. You can't really undercook that. It's almost been every element from a provider perspective, but also from a community perspective. We've championed innovative models like the drive-through, and also in section 2.21, where we give a little bit of a breakdown on how we've been able to work together with voluntary sector partners and our community groups and our faith leaders, as Amanda helpfully mentioned earlier, to understand how we're making sure that the vaccine is available to everybody who needs it. And I think it's taught us in a very short period of time an awful lot about our communities, and probably from a broader sense than the vaccination, which we'd already started that conversation with the What Are We Missing work, which Amanda's been instrumental in, looking at how we make sure as a health and care offer we are able to tailor that to our communities that have different needs. But when it came to the vaccine, understanding what was stopping people from accessing the vaccine, even though they're in the more vulnerable groups, took a lot of one-to-one conversations, and those conversations being had and instigated by familiar, trusted leaders within the communities. And out of that, I think we can absolutely say that going forward, we now have a better handle on where we've got pockets of inequality or people that need a different offer of support, but equally we've got probably a better understanding of the organisations that can influence in that area, and actually from a commissioning point of view, where we need to make sure that we support those organisations to do more going forward. As we speak today, in 2.2.1, you can see they've taken the vaccination bus to Newmarket as part of the Bury Islamic Cultural team, have gone up with some of our team to vaccinate some of the individuals that live in houses of multiple occupancy and other risk groups. So it'll be interesting to see how that plays out today. But it was everyone was quite excited this morning when they were going off on the bus. And the last point I just wanted to bring some highlight was we're doing a significant piece of work around homelessness in West Suffolk. This has been supported by our quality improvement team, which has been going from strength to strength, and we chose as a system to focus our initial work around our homeless population, led by Ian Gallen, our district and borough colleagues. And we kind of chose that because it was quite a defined population, and it involved a huge list of providers that all have provided care for these or support for these individuals separately, and bringing them together and understanding actually if you collaborate, what's the different offer that you can make. And I think the list of stakeholders are in the paper, but what's I think coming out of it again is bigger than just the offer for the homelessness patient cohort, it is actually more teaching us about provider collaboration, which is obviously a key theme of the white paper. And I think often when we talk about it, we think about the kind of big provider collaborations, looking at acute hospitals, mental health hospitals and beyond. And I think this is a piece of work that really does show that it's everybody who is involved in a care package or wraparound for an individual needs to be able to collaborate and be kind of given the tools and be empowered to work differently. So I think the learning that comes from that will be significant and feed into quite a lot of other elements of work. So I think I've probably said enough. That's all I was going to pull out of the paper, and I'm very happy to take any questions.
Thank you, Kate, for a very comprehensive whiz through a lot of material. So I've got a number of people who want to ask questions. David, you were first.
Yeah, Kate, thanks very much. My question is really about sort of the ongoing journey of integration. Obviously, the white paper talks very much about place, and we're very well placed given all the work we've done on the West Suffolk Alliance for that. But there's also an obligation, as you already said, for provider collaboration, which will impact on West Suffolk. Has the ICS, CCG or the Alliance given any thoughts as to how best to achieve that? Is that going to be something that's driven by the ICS, or is it going to be very much up to the individual provider organisations to reach out to other provider organisations within the region?
Thank you, David. There's quite a lot of work already going on in this area. I don't know if Helen wants to come in rather than me talk. I think Helen's been involved in the conversations because it affects the kind of here and now operationally as much as that kind of longer term strategic piece. And what's happening at the moment, I think, is the building blocks for that. Helen.
Thank you, Kate. I joined a regional meeting the other day around this very topic that had some of the national team interacting with us. There was an offer as well to come and speak from the national lead, so it would be my intention for us to maybe bring that forward, maybe for a board workshop of some description. I think it's fair to say what they're looking at the moment is a broad range of options, and recognising, I think, there are an awful lot of collaborations that already exist, the clinical networks and collaborations that we see. Lots of conversations about people like ourselves who may have collaborations in a direction outside of the ICS. That was acknowledged as being positive and acceptable. And I think this initiative is really about making sure that they are truly delivering what they're supposed to be doing. Lots of discussion around using the GIRFT information for peer review across clinical networks and those kind of things. So I think there's all to play for at the moment, but I think it's bottom up, top down, and all opportunities in between as it stands at the moment.
Certainly, the ICS board has great appetite for this and is driving it. I think my only slight concern is occasionally they get a little bit inward looking to the ICS, but actually, when challenged, they fully understand. Networks are different sizes, different mixtures, different types of collaboration. Rosemary.
Thanks, Sheila. Hi, Kay. Your paper. Thank you very much indeed. It's a simple question, and I'm sure it's a quite complex answer, but I wondered if you could give a flavour of what is the process for agreeing priorities on the different initiatives, and how difficult is it to reach agreement on those priorities, given that you're working with lots of different partners and so on? I can't imagine what that process is.
So it's a process that requires more development, probably a more formalisation. But as it stands at the moment, we have 4 ambitions, which is what I've lumped the papers into, and they ripple out into mirroring the ICS ones and are in line with the trust strategy as well. So What we've tried to do, because there is something about the Alliance not actually being an organisation or a thing, it is an agreement to work in partnership, and it's a culture and a kind of a prioritising of saying, actually, if we can do something together that adds value, that we will do it. And I think that's the tricky piece about where we're at the moment is it's almost becoming a being, an entity in its own right. And I think when we've come to make decisions around priorities, using the example of homelessness, we had a shortlist that as a system exec we signed up to, and then that was then brought to a follow-up meeting with some additional data, pros and cons about the prioritisation of the pieces of work. And that's why we settled, the system exec group agreed on the homelessness element. So that's one piece of it. But then in terms of other priorities, we've openly committed to developing our community and locality model, and investing as much as we possibly can in terms of time and changing our ways of working into making that an integrated model. So those kind of commitments are kind of implicit and have been from the start. So it's kind of a mix. So if there's a decision to be made, it goes through the governance process of the system exec and the steering group. But there is also a lot that is just our operational business as usual. And I think that is a big chunk of what we take for granted. Not every part of the country is working in this way, and I think we kind of forget sometimes what we've achieved. So it is quite nice sometimes to make the comparison and think, actually, no, we've got a fantastic foundation for how we move forward. I've made that a nice long-winded complicated answer for you, Rosemary. I'm not sure.
No, that's great. Thanks, Kate. Really appreciate it.
Thank you, Kate. Louisa.
Kate, I think the sort of development of the integrated teams is quite exciting. And I looked to your table on 2.8, and every single sort of network has signed up around the mental health practitioner and social prescribing. Have we underestimated the demand post sort of as we move out of COVID, or, will we evaluate the various sort of demands that are placed on those teams to understand what's really worked well and how we move forward and develop those teams for the future? Because I think this is really quite an exciting piece around understanding our demand and reducing our demand in an acute setting, if we can deal with it in the primary care and the integrated team world. And there's a supplementary to that. I understand there's different models of social prescribing across the county, and it's just, do we understand what really works? Is that down to locality, or will we look at other models and think about how we could perhaps take the best parts of that and implement it in West Suffolk?
Brilliant. Can I take those in reverse order? So the social prescribing piece is incredibly timely. So we do have a slightly different model to our most immediate neighbour in East, in that our district and borough council host and provide our social prescribing. And I've recently had a new addition to my team, Rebecca, who's come from Essex County Council, where she was looking at social prescribing across that whole enormous geography. And she's come in to have a look at ours and started that conversation, because we are over a year into our model, so it is timely that we have a look. Are we maximising? Because the need is, you could double, if not treble, that as a piece of capacity, and there would still be an ask on it. So what we've agreed to do is look at the model and understand kind of what the need is, but also what potentially the funding requirement would be if we were looking to we know the impact, so if we were looking to commit to expanding that part of the workforce. So I'm happy to bring back a briefing. They haven't actually met yet, but I'm quite excited at the prospect, because I think it was a piece of work that got slightly sidetracked by the national policy. We'd already committed to it, and suddenly we had a new set of rules that we had to abide by. And I think we've gone past that now in terms of our level of understanding. So our next step is what works for us. What do we get the most value for as a system? And the second piece around the mental health and I suppose demand more generally, and how that underpins those staffing groups. We are just introducing those individuals, so they've all ticked yes, and we're in a new phase of our relationship, I think, with our mental health provider, in terms of them actually becoming much more closely aligned to primary care, and understanding what that means, what impact those individuals have on that overarching workload, is part of the work in progress when we get those people firmly embedded into practices, which should be over the next couple of months. But the recruitment for them is going through now, so we're at the beginning of the journey. But we do know from a mental health perspective that our demand is some that we experience at the moment is something that we've never experienced before, just the level of it, and I'm sure that's coming through from your channels as well. So we do need to prioritize the kind of the workforce in that area, but it's difficult to find, and I think that's part of the issue.
Thank you very much indeed, Kate. I've got Sue and then Alan, and then I think I'm going to have to wind up and we're going to have to move on. So, Sue.
Well, Kate and I have already discussed this actually, so it's not really so much of a question, it's more of a comment to just say that with regards to the sort of flexible workforce and how we look at workforce modelling, we do have the ICS oversight group for advancing roles, and I know we talked to Kate about making sure that PCNs are represented there so that we can really cover off a lot of the roles, because I noticed advanced clinical practitioner is missing from your table, but we will cover that off.
It's good to know there's the connectivity. Alan.
Okay, in Steve's paper, it mentions the new early supported discharge package. I noticed that's such. Do you see more examples coming up where the two alliances will work together? And if so, is there a clear governance and accountability route for that sort of work? It's not clear to me who kind of has oversight of that in what's called the Suffolk Alliance, which I didn't know existed.
Do you want me to pick that up, Kate?
You can do.
So you might recall, Alan, this was a specific piece of activity that was not quite tendered is probably the old-fashioned word, but by the CCG to provide a county-wide service. And we put in a bid with ESNEF colleagues to bring it back in within the county. So we are the key contract holder, but the service is delivered by ourselves for the West and ESNEF for the East. So we have got an overarching governance, and then we've got local teams delivering within each local alliance.
Okay.
Thanks, John.
Thank you, Alan, for the question. Kate, can I thank you very much for the report? I think it is just so encouraging, the distance we're travelling. And Alan touched on governance. One of the things that pleases me is that the Alliance Board, I'm really thrilled they've got an independent chair. I think that's a big step. And I think the fact that now they are hearing more independent voices around the table, and it's no disrespect to you as an executive colleague or any of your executive colleagues, but I think that breadth and that check and challenge that can be brought by that, it is good governance, and it's really pleasing to see that extending. And I know from an ICS point of view, you know, the ambition is that all the alliances will move in that direction. And I do think that balance, and Alan, you kind of raised, a number of you have raised the issue of what's Suffolk wide and what's alliance level. I think, you know, everything that can be local or is appropriate to be local should be, but on the other hand, do whatever it is at the right level. Some things will be very local and some things will be pan ICS, as we know. So, you know, it's getting the right thing at the right level. So thank you, Kate. I'd appreciate any feedback on Kate's report. From the point of view, this is the first quarterly report, so please feel free to give me any feedback afterwards, and Kate and I will have a discussion before the next quarter comes round. So thank you. Okay, if we could then move on, please, from Kate's report to the operational report. Helen, please.
Thank you, Sheila. So I will assume that the paper's been read. There's just a couple of things I'd like to call out. We are really pleased to be in a position where we have 0 COVID positive patients within the organisation. But as Steve mentioned and is mentioned in there, Ipswich sadly have had a local outbreak recently. So we're really keen not to be complacent and to encourage strict adherence still to all of the infection control procedures, because as we've seen before, it would be really, really easy for us to be in that same position. We're fortunate, however, because that is partly what is enabling us to manage the organisation and flow through the organisation in a better way. As the paper says, we've managed to reinstate the short-stay medical ward and managed to really focus the teams back on previous effective ways of working that we had struggled more with during COVID, and we've seen some really, really positive results as a result of that, which is why we're working really well against a backdrop of activity through the emergency department that is back up to pre-COVID levels, and in some cases above that. We had 290 patients through the emergency department the other day, and we are holding strong. So real credit to the teams involved in that. We've seen some early SAGE data that would suggest that there is likely to be another surge. Depending on which data you look at, that surge is anywhere between June and September. But the suggestion is much more that this is a surge in the local population, but due to the impact of the vaccine programme, the impact on health care and hospital beds is expected to be reduced. The next section talks very much about the RAC Plank programme and the operational impact. At scrutiny this month, we reviewed more recent information that's resulted in quite a significant change in the plan, and we've had to respond to that operationally. We are therefore, by next week, will have decanted critical care into the overflow critical care that we created during the pandemic to allow the fail-safe works to fully happen in critical care and to move them back. We are already working in 2 wards, and by the end of next week, we will have moved to be working in 3 wards. So the challenge for the operational teams is significant, and the need to react to changes is also significant. So again, I'd just like to recognise the joint effort that's going on between estates colleagues and operational colleagues, and the significant amount of work that is involved in that. The plans are really based around what we hope is best case quite challenging in terms of delivery of some of the estates work, and we will have to react and change plans accordingly if things change. We've done a couple of really quite detailed staff briefings and are trying to alert people to the fact that this is a very changing programme. It doesn't come with a level of certainty, and trying to get people to kind of be forewarned, if you like, that we may suddenly have to change direction, change dates, move focus, and we're very alive to that. But we have now re-established a core resilience team with some key operational people, as well as additional emergency planning resource and business support to take forward some of this and to try and assist teams to manage that as quickly as possible. In terms of elective restoration, that is going well. We now know from the planning guidance, as outlined there, the core requirements in the planning guidance to deliver 70% of 1920 baseline activity in April, and then for that to rise by 5% a month through until we get to 85% in July. We're also really aware that that requirement in the planning guidance is not going to go any way to reducing waiting lists. And therefore, whilst that's the minimum we need to do, we're working really hard to try and secure additional resource to allow us to move further and faster, notwithstanding obviously the concerns about the impact on staff. So there's a fine balance that that is front and centre of our thought processes in terms of how we treat the patients and how we look after the staff. And that's, that's a bit of a knife edge at the moment, but we're very live to that issue and managing that in the best way that we can. There are conversations that are happening in order to get some recognition of the issues we will face during the theatre closure programme, because on this particular site we will not be able to deliver inpatient activity at that level during the theatre closure programme. And I know conversations the regional team are really, really live to that, cited on that and supporting us with that. And there are conversations that are happening in order to get some official recognition of that. So we will update the board as and when we know more around that. If I could just move to the question that was in the paper, which was, thank you for the question, because it's given me an opportunity to just explain that if we look at pages 54 and 55 and convene, you've got a weekly activity report. We've included that for the last few months and people have found it helpful, but it does come with a bit of a health warning. It's weekly data. Usually we report monthly data, and what I would advise people to do is look at the two columns. So if I particularly pick slide 55 and we look, for example, at colonoscopies, if you could orientate yourself to that, you've got two columns. One is the 4-week rolling average data, and then the last column is the latest week, and it says at the top provisional. And the reason it's provisional is because there's a lot of data catch up, coding, data quality, all sorts of things. So that's the reason why that column is showing for us, particularly in all of the endoscopy modalities, which don't, that activity isn't recorded on eCare. And that activity needs to be coded and caught up, which is why it looks particularly low. I would suggest there's quite a significant amount of data quality generally from some sites, because if anybody is delivering 6,567% more activity than they were in 1920, I for one would love to know quite where all those patients are coming from and how they're doing that. So that there are some health warnings around this. If you're going to compare us with anybody for this type of activity, I'd be looking at the other rack plank sites where things like social distancing in waiting rooms and those kind of things are playing in here. There are also sites which will be using vast amounts of private sector activity. ESNEFT is one of those. They have access to 2 significant independent sector providers that are delivering a lot of this diagnostic activity for them. And our local BMI, whilst working collaboratively with us, just do not have facilities to do that. It is a much smaller operation. What I can say is that I also have, because this is March data, I've got sight of and the cumulative rolling picture for April which I'm really encouraged by. I'm conscious it's only, 3 weeks worth of data points and one swallow and all of that, but it is very encouraging in terms of the level of activity we have managed to deliver through April. And we will continue to push as much of that until we are impacted by the closure programme. So I hope that does answer the question around the data. Please come back to me if there is more information that people would like around that.
Thank you.
Finish at that point, Sheila. Happy to
I
take
have to see Florence on my screen. I hope that covers your question, Florence, but if not, come back to us.
Yeah.
Thank you. I've got 3 people waiting to speak. I've got Rosemary and then Angus and then Richard. Rosemary.
Thanks, Sheila. Thanks for your report, Helen. And I know you're dealing with an incredible amount of complexity around everything that's going on there. But I was just wondering, how are you managing to communicate with patients about the timing of the different treatment pathways? That must be a completely different level of complexity. Could you just sort of give some assurance about what's happening on communication with patients, please?
Certainly can. You're absolutely right, Rosemary. It's an incredibly challenging picture, and there are a number of initiatives we're trying. There is a very detailed comms plan generally talking about our rack plank issues, because that overlays the waiting list issues. And I know Helen is just waiting, I think, for final regional approval around that. But that covers off a whole list of stakeholders, not, patients, the local population, etc. in broad terms. In specific terms, we have a GP section on the website that we update on a monthly basis across a range of across every specialty and every diagnostic modality. And we know GPs, often patients are communicating with GPs, so that's one of the options. Not that I'm suggesting GPs are the first primary method of communication, but we do provide that to help. We managed to secure some funding for some additional resource that we were trying to put into the PALS team with Cassia to pick up and take. That would obviously be more reactive. Unfortunately, they haven't yet. The first round of recruitment wasn't successful, but we continue to try to do that. We're also keen to use the doctor-doctor platform that we've deployed. So at the moment, we've been doing a lot of communication by literally phoning the longest waiting patients to get some form of clinical validation. That is hugely time consuming, and actually we're only able to deal with the tip of the iceberg. The doctor-doctor platform has 2 things that we think will be really helpful. One is called the quick question, and it's a way to quickly interact with patients and get a yes/no response. And we plan to be able to use that to update people in terms of timelines, but we can ask them simple questions like, if it was possible to move your care, for example, to a facility at Ipswich, would you go, would you not go, those kind of communications. And we're also going to use it to engage with patients in a more interactive way, so we can pose them a set of questions. Are you needing to take more pain relief? Have you needed to go to your GP? Have you attended ED? Are you sleeping? Whatever the relevant question might be, and get some responses from patients to enable us to do a first level of triage, and then we can focus in on the patients that might then need that direct intervention. And finally, we're talking with specialties, but we want to get the approval from the regional team of some of the lines within the communications approach, bearing in mind that whatever we say around RAC affects many other organisations. But then we're talking to clinical teams about some core text with some specialty specific text either side. And then again, for patients who are signed up to the patient portal or doctor, we'd send those out via that route. And for other patients, we'd send them letters. So we're just finalising, because this is going to need to be a kind of probably a 3-monthly rolling update to our patients. And it is a massive, massive job. So looking at doing it in lots of different ways.
Okay, thanks, Helen, and thanks for all your hard work.
Thanks, Helen. Helen, I've got the other Helen on screen. Is there anything you just want to add from a general point of view about communications with patients around these issues?
Yeah, I think Helen has come. I think in terms of how we do communicate this to the public, obviously there are huge amounts of complexities around this, but we are looking at how we can do some media work around this alongside those patients to letters, and also those more bespoke briefings and communications that can go out from teams, but also how we can brief PALs, we can brief medical secretaries, so that they know what to say to patients when they're being called. So I think a mixture of kind of proactive and reactive comms is the blend. For us in the comms team, the priority has been around the structural work that is obviously going on in the hospital and getting those communications out. And now we're shifting our focus to this piece of work as well. So working as hard as we can with the resources that we've got.
Thank you very much indeed, Helen. That's helpful. Richard.
Thank you, Sheila. We talked before about the dangers of, as we come out of the pandemic, the pressure to speed up our recovery plans above and beyond what is realistic and reasonable. And I'm just looking at the opportunity to bid as an accelerator system, and I just worry if that's the start of this sort of ratcheting up process. So I just wanted to know, with my staff wellbeing guardian hat on, what we're doing to protect our tired staff from that sort of pressure, and how we can make sure that if there are plans to accelerate our recovery program, that they're developed by the teams that are going to have to deliver them, rather than being a sort of top-down pressure.
And as I say, there's a real fine balance between how we protect our staff and how we manage what is a growing disparity between the waiting times for patients in the east and the west of the county. We are looking at the accelerator programme, and we'll bring back to the board, if we are successful, greater clarity around that. But I can assure you, one of the key drivers, as well as bringing some additional capability and capacity into the system, and with that I mean additional people, and using any money that may come down for that. But there's a big piece around how we transform the delivery of services to make ourselves more sustainable in the future. And one of the ideas we've had around that is absolutely going out to clinical teams to say, if there was an opportunity to pump prime something, what would you want to do? What do you think are the opportunities for you in your teams? And we've been having some of those conversations anyway, because regardless of accelerator site or not, those are the things we need to understand. So we've got a plethora of initiatives coming forward from within urology, for example, within ENT, that already say if we could have X, Y, and Z, we could do much more activity in day surgery, much more effectively than we can in the inpatient theatres. There is already an existing outpatient transformation programme looking at how we reduce unnecessary outpatient activity. And I think, and I know you've sort of got two hats on, but it's really, really important that we look at this as a system. It's not just about how we stop doing what we're doing in the acute, but what is the capacity that needs to be out there in order to make that happen. And we would hope that we can pump prime some of that transformational work to make ourselves sustainable into the future.
Thank you, Helen.
Thank you.
Sorry, Richard, were you happy?
No, I just want to say thank you. That's very helpful.
I just wanted to comment, catching up with a couple of senior clinicians and the chair of MSc in the last week or so, you know, there's a real mixture across the trust of people who are desperate to get on and to treat as many patients as possible, and people who are tired. And a point the chair of the MSc made to me, it's even mixed within departments. I suppose it's about different people's response to pressure. And, you know, she said there are some people who really want, because it's positive, it's doing, you know, after the epidemic and the peaks of that, to do something really positive and good for your patients is actually quite restorative in a way. So I think it's sensitivity to individuals, to teams, to right across. Okay, Helen, thank you. And thinking of teams, I think, you know, as a board, and I know others have mentioned it, I don't think we ever give enough praise to the ops team, because they are juggling an incredible load, and it's constant. You have enough juggling with an epidemic, let alone with a building as well, that's less than fit for purpose at the moment. So Helen, my thanks from the board to your team. They are amazing. If we were doing the awards in the near future, they are definitely a team that deserve awards, because they're the ones who make it possible for the frontline staff to do what they do. They're the ones who get the patient to the doctor and to the nurse and to the place they need to be.
Thank you, Sheila. I will pass that on. I think you're right. They're often looked to for providing the solution, and just at the moment there aren't necessarily solutions to all these issues. So I know they feel the strain. Thank you.
And like finance teams, they often get kicked when people don't get what they want.
Yeah.
On that note, I'll move to finance. Thank you, Helen, very much for your report. Craig.
Thanks, Sheila. I was just thinking that was a nice segue, because talking about fantastic teams, we turn to finance. And this is the time of the year when we talk about 2 financial years. Genuinely, the finance team have produced a full set of accounts within 3 weeks of the year end. Our accounts went to the auditors earlier this week. And that is a genuine achievement to do that under the circumstances we find ourselves at the moment. So the end of the last financial year, I think we predicted what the result was going to be this time last year. So the result was indeed a break-even position. So we have sent the accounts to the auditors with showing a small surplus of £145,000. That's obviously subject to audit, and we will go through the process with the auditors over the next month or so. There isn't really anything new in terms of the financial position. Probably the most significant element is on the last page of the finance report, which was the capital expenditure that happened in the final month of the year. I think, again, we we're one of a tiny number of organisations across the whole of the east of England that met their capital target. We have done that consistently over the years, and I think are the only organisation that has consistently met its capital expenditure target. An awful lot of credit needs to go to the board around that because of the approach we take around capital. We do the right thing and work on the basis that the rest of the NHS will catch up with us at some point. So we do take more risk than most other organisations, but we do it with patient benefit firmly in our minds. So a massive effort across the organisation to spend capital, and you can see what happened in March on the final page of the report. In terms of the impact of that, you will see when you do get the final accounts, and indeed it's referred to here, the cash balance in the organisation stayed very high, because with that capital expenditure that happened right at the end of the year, there's an awful lot of that expenditure that hasn't been settled in cash yet. And so we've got a significant cash balance at the end of the year, despite the advance payments unwinding in March. So our expectation was that our cash balance would drop in March as we lost the impact of the advance that we were getting from commissioners. In fact, our cash balance remained high because there's an awful lot of bills that have been settled in April. So cash will return to being a significant focus for us as we move through the financial year we're now in. So if I turn to the 21-22 financial year, the board approved a plan that was based on some significant assumptions around income, and we are just working through with colleagues from the ICS and NHSEI what the income position will look like. We do have an income figure for the first half of 21-22, and we're just working through what the impact of that will be, and what sort of financial position we'll have. It's looking better than the position that was signed off by the board within the last couple of months, but there is still a degree of uncertainty around that, and we'll talk more in the closed board about what the financial position is. The only other point I would want to mention at this stage is around the cost improvement programme. So again, as we've been saying all the way through the last financial year, our ability to deliver a cost improvement programme has been constrained by the impact of the pandemic. We believe that position will sustain into 21-22. So at the moment, our planned cost improvement programme relates to the second half of 21-22, but that's obviously subject to change. Other than that, I wasn't proposing to highlight anything in particular, but I'm happy to pick up any questions.
Thank you very much, Craig. David, I've got your hand up.
Thanks, Craig. Just talking about capital and really looking forward to 21-22, and I think the capital plan is still being worked on. But just thinking about capital expenditure in general, we obviously have got the rack plank issue where we're going to have to spend capital. But on the other side, we've potentially got a new hospital coming along in 5-6 years. And probably what we don't want to do is spend unnecessary capital on a building that may be subsequently closed and have to be written off. So from a sort of value for money perspective, what's the general approach going to be in terms of capital expenditure on the current premises, other than that is absolutely necessary for safety reasons?
So I think you've just described the approach, David, and we've talked about this at previous boards. The expenditure on our existing building is a waste of money to a certain extent. So whatever we spend on that building, we're going to put bulldozers through within the next few years. And so our approach is exactly what you've described. So we should be spending money in order to maintain the safety of the building, but we need to very carefully scrutinise any other expenditure. We're looking to ensure that where we spend money on equipment, that equipment is portable. So any new equipment, pathology being the most significant example recently, all of the equipment that we bought in pathology will go into any new facility that we build. That's often not without costs, so that there are costs associated with moving equipment, but it's much less than buying new equipment. So the principle that we're working to is minimize expenditure where possible, make sure expenditure is sustained into the new facility, but we will be in a position where the quality of the building, so safety needs to be ensured, but the quality of the building is likely to deteriorate as we get nearer to the date when we're going to move into a new facility. I hope we've seen that in a number of other healthcare organisations, most notably Papworth. So Papworth spent, I don't know, 15 years where they were going through a period where they were letting their old facility deteriorate with the promise of a new one. I hope the period we'll do that will be significantly less than that. It's got to be, but it is a feature of moving out of one building and into another.
Okay, fine, thank you.
Thank you, Craig. I have no further questions, so thank you, Craig. And yes, I wouldn't let your team go unthanked, because I do know what end of year is like. I remember some midnight oil being burnt in organisations in the past, quite literally. So please pass my thanks on to them. Of all the years to have to do the task, this is a challenging year.
Thanks, Sheila.
So thank you. Now, we have got a 10-minute break. I'm going to cut that, and I'm going to apologise to Amanda and James. Please forgive us, but I am going to take a 5-minute break. You've been sitting still a very long while, and it is not good for your health to sit still for that long. But could we cut it to 5 minutes, please? You can get up and make a very quick coffee or do your exercises or whatever meets your requirement, but at least it gives you a chance to move. So my apologies, James. My apologies, Amanda. We will be no longer than 5 minutes. Jeremy, do you want to kick off? Well, and then we'll introduce Amanda and James.
Yes, thanks, Sheila. Several things I'd like to cover in my report today, but absolutely would like to start with James and Amanda, who I'm so grateful have been able to join us this morning. As I have said before, the independence of the Speak Up Guardian function is really important to us, what you have as an appendix to my report is what Amanda themselves have written and submitted, and I've asked them to take us through the headlines from that, and then we can move into discussion and questions on that, and then I'll follow on with some other things from my report. So Amanda and James, over to you. Thank you.
Amanda and James, welcome. It's really pleased to have you here in person to present your report. And I won't steal your thunder by saying any more. I'll let you go straight in.
Well, thank you very much. And thanks for waiting to 11 so that I could come along. Amanda's been in post for 6 months and I've been in post for 5 months. And I think we had a discussion yesterday and we're both, very glad to have another person doing this role together. And I think that really strengthens the role, and it enables us to discuss things and talk things over, which is really helpful as well. We've been very grateful to the support we've had from the senior management, so thank you for that. And it was quite interesting writing the report and looking at the things we've done. It showed us how much we had done over the 6 months, and was quite gratifying to do. So in regards to the numbers coming to us, I think there's been a quite marked increase in people coming to us over the last 6 months. So there was over 27 cases we've had come to us. I think it's difficult to get any sort of overarching idea of the things which are coming to us, or take a great deal of information from those. But I think one thing we would stress is the importance of line managers. Again, this corresponds with what's happened from what matters to you information, and I think that middle management have a difficult job, and they're interacting with most of the staff, and they're where concerns are raised, and concerns are raised about those interactions more probably than any others. So I think that's an area we need to look at. The other thing with just the two of us, I mean, we're exploring how we get more information out to people, support people locally within the workplace. So we're looking at developing ambassador roles within the trust, so Freedom Speak Up ambassadors, and it's very fortuitous that the National Guardian's Office has just come out with some guidance of how to do that. So we're exploring that. Amanda's been very good. She's had a word with the trusted partners and asked them how their role how they think their role has worked, and so we're using that information to inform what we do next. So those were the main things I wanted to pull out of what we had to say of our report. Amanda, did you have anything to add?
Yeah, hello everybody, and thanks for the opportunity to present really at the board here. The only extra thing that I would add to that is that we've been talking to Jeremy about training, and it is one of the recommendations. They're not mandating it, but it is a recommendation from the National Guardian's Office that everybody within the organisation does have some sort of training regarding freedom. So we're in conversations with Jeremy about recommending that at induction, or if people who are already in post undergo the e-learning programme, which has been designed by the National Guardian's Office and is available on e-learning for health. And there's also a module for managers, and we would recommend that's undertaken by all managers in the trust as well. So that's the only thing I think. But yeah, I think we're working well together, and I think things are good, really good. And we've still got lots and lots to do, but I'm pleased with what we've done so far. That's it for me, I think. I don't know if anybody's got any questions. Or
First time. My mute on. I think what pleases me is the fact that we originally advertised for one person and we went for two. And hearing you both talk, I can see that we're getting a much richer picture by having two people who can interact with each other. And Richard, I'm seeing you nodding, and in your role as Senior Independent Director, I know you meet with Amanda and James as I do. And I think it is a great strength. I didn't know if you want to add anything, Richard.
No, just to say that I think they're doing a fantastic job. I agree, having two of them is really important, and the fact that there are so many people who are coming to speak up to them is a credit to them and their visibility and increasing visibility in the trust. It's been a challenging time, of course, to be a Freedom Speak Up Guardian in the current climate, but very impressive what they've achieved so far.
But the exciting bit is what you do next. So Alan, Angus, Steve and Rosemary.
Thank you, Amanda and James. Good to see you face to face as well. One request for the next iteration of the report. Could you give a little hint, without giving away confidentiality, of the impact or outcome of these interactions? Because although what you've recorded is the fact that you've had the interaction, what I don't quite see is, did people feel it moved the issue forward or resolved it or did something to air it? So that would be really helpful if you're able to give a hint of that, please.
I think that would be helpful to us all. Thank you. Angus?
Amanda, James, thank you for your report. When I reflect back on some of the reports we've received in the past, this is so much richer and it's actually very reassuring. So thank you. We've seen a great step forward. I've got actually probably a question for Jeremy more than you. The report, in a very polite and delicate way, says that it raises a number of even better if throughout the report. And it struck me that as an organisation that should be listening very carefully, we should be really clear on what concrete actions are being taken in response to those requests from our Freedom to Speak Up Guardians. I wondered if you wanted to comment on that.
Yeah, absolutely. I hate to inject a note of pessimism, but the board will remember, of course, from my presentation from the staff survey, that staff's perceptions around these issues took a bit of a dip in the 2020 staff survey. It is the thing that I am most concerned about from the staff survey. It comes together in the safety culture theme, which is the way the staff survey frames it. My report makes reference to some workshops that we're holding, two of them later in May, to co-develop and strengthen the people plan with staff representatives and staff ambassadors. Amanda and James are very much involved in that. Safety culture and speaking up, and all of the ideas and proposals that are in this paper will be fed in through that process.
Fantastic, thank you.
Thank you very much, both of you. Steve?
So in part, Angus, you picked up what I was going to ask, and Jeremy also covered it, which was in essence around the staff survey. But I just wanted to both thank James and Amanda for all you've been doing and really embracing the role. Given what the staff survey says, and there has been that dip in perception around safety culture, I think the things that are detailed in your report around even better if could be part of that supercharged response to try and both meet some of those concerns in the staff survey and also further embed speaking up as part of our culture and so forth. So I'd welcome any additional thoughts, James and Amanda, you have in terms of where, as a board, we could best support this agenda. So I've heard from what you've said, really getting focused around line management and support for them. But is that the priority that you'd want to see the board really get behind, as well as an extension of ambassadors?
Thank you. Shall I take some questions, and then I'll ask you both if you've got anything to add at the end, and the same for you, Jeremy. So Rosemary.
Thanks, Sheila. It's good to meet you, James and Amanda, and it's encouraging to see the work you're doing, so thank you for that. Like Angus, my question is probably a bit more directed towards Jeremy. You made a mention in the report about the Just Culture programme as a possible improvement area. Is there any plan to link the freedom to speak up to the Just Culture work? So it seems that there's sort of lots of initiatives operating separately, and I wondered whether there's a plan to bring it together into kind of one cohesive cultural programme, so that the staff understand this is, you know, it's a holistic approach, if you will, to actually improving the culture in the organisation, and would that help? And also, James, you made a mention about the What Matters to You survey. I mean, would it be applicable at some point in the future to redo that, to see whether some of the actions we've taken, staff recognise that we're trying to move forward, and, you know, to identify where the action still needs to be taken?
Thank you for that, Rosemary. I think you raised two really good questions, and James and I had a conversation a while back about the kind of need to bring those different initiatives together to form a West Suffolk cultural model, if you like, which encapsulates them rather than them feeling just a little bit separate at the moment. And I think the What Matters to You, it was the way it was conducted and the way it was done was particularly, I think, empowering, and we were very fortunate to have some very inspiring people to do it. So I think it did bring some very rich material forward. Before I close, James, Amanda, would you like to add anything before I hand back to Jeremy?
So I think where we wanted support from the board was around the ambassador's role. The Guardian's office said that should have some protected time to organise that. So that would be for training, ongoing support provided by the Guardians, we would visualise that being, and maybe some discussion groups, so when people could get together and just discuss cases and how they were handled, and if just to, you know, share that learning. So that's one of the areas. So with the cultural programme, absolutely, we've discussed that with Jeremy and other members of the senior management team that we've met, and said, you know, there is a lot of good stuff going on, but it all needs time. You know, it would be much better if it was all tied together, so that we're all working and using the same language and working together under a structure. And then in relation to repeating what matters to you, I think that's a discussion. I think that's up to you, really. We have the information from the staff survey, which gives us some information about speaking up and the perception of it. And I think, you know, that will carry on, won't it? And we'll get that information back. Whether you'll be able to get out the information about the relationships with the middle management, I don't know.
Thank you very much indeed, James. James and Amanda, thank you so much. I will hand back to Jeremy now to conclude and to carry it on, but thank you, because I think you've done an amazing job at a very challenging time. It couldn't have been a more difficult time to start your role, but I know you're ambitious to begin to work in a more normal way, if there's such a thing as normal anymore. But I really appreciate what you're doing, and I know staff do appreciate it too. So if I can hand back to Jeremy at that point.
Thank you. Just a couple of comments in relation to Rosemary's question. I think we have a number of overlapping sort of cultural priorities and things that we're working on. Really, to reiterate what I said earlier, one of my aims for the work we're doing in May with staff representatives and staff supporters is to try to get one single narrative around what our cultural priorities are, what is our West Suffolk approach to it. And actually, I want to try to translate it all into everyday language. I probably want to step away from using the phrase just culture with staff, because I don't think most people know what it means. I think I would much rather morph towards describing it in a way that cuts through to everybody, that makes sense. So yeah, that's certainly my approach. And as I said, the safety culture work will be absolutely embedded in all of that. In relation to further surveys, I probably, well, apart from the national work around there being a quarterly staff survey, and that may be forthcoming in the course of the next few months, I would probably want to sort of consult with staff reps about whether they think that's the right time yet, or whether they would like us to make more progress with our people plan before we do. But I'll certainly take that away.
Thank you, Jeremy. I'm not opening that for the discussion today. We've still got a lot to go through the agenda.
No,
so
that's fine. I just wanted to make sure I didn't. I just wanted to make sure I didn't miss out on what Rosemary had suggested. In relation to the rest of my reports, you have the Putting You First winners for April. Let's name them: Ollie Best, Lucy Webb, and our My Wish charity team, and you have the citations there on page 73. Yeah, huge appreciation from all of us for the extra lengths that they've all gone to in different ways that is described in the report. We will absolutely, as was suggested by Alan at the start, by Angus at the start of the meeting, make sure that they're named in the minutes. And they'll be celebrated and thanked in the usual way. You also have an update in my report on everything we're doing on staff wellbeing with an appendix if you want the detail. In relation to mandatory training and appraisal, there's a quarterly update provided there in the report. The particular question from Liz at the start of the meeting around appraisal related to making sure that we know about and encourage and make appraisals happen for those staff who have perhaps routinely missed out on one. If we're just reporting on who hasn't had one in the last 12 months, we're missing out on the prioritisation of who might not have had one for the last 3 years. And actually Liz's question has prompted me to think about how we can delve deeper into our data. The HR business partners are working with the divisions to agree improvement trajectories for appraisal and mandatory training. Let's use the data to prioritise those staff who have gone the longest period of time without one. So thank you, Liz, for your question, because that's really prompted my thinking on that. You've also got some medical staffing updates in the paper, which I'll happily take questions on, and one recent consultant appointment. Yeah, questions and discussions probably the next best thing, and I'll stop.
Thank you very much indeed. I've got.
Thank you, Sheila. I just wanted to offer that bit of assurance that prior to the arrival of the HR business partners, etc., people might recall I did do quite a lot of work on appraisals certainly with the operational teams, and we used almost a PTL approach. So I can assure people that our focus was not just on overall numbers, but those who had waited the longest and those who hadn't had a record of one. So I think some of that is already in train as well, Jeremy. But I'm sure it will benefit from your focus. And of course, the stuff I did was only in the operational divisions, but there has been work on that.
Thank you for that, Helen. Are there any other questions or comments on Jeremy's report? Because if not, I will segue into maternity. So, Sue.
Thank you, Sheila. Well, Karen, as our head of midwifery, is here to, as always, present her report. So I'll hand over to Karen, and then between us, we'll take any questions.
Welcome, Karen, again.
Thank you very much, and good morning again. Okay, so hopefully you've all received my paper and read. So a few things to you if possible. So the first thing is eCare Go Live. So we finally have done it. We're now, like the rest of the trust, and are live on eCare. But one of those things is we are having a little bit of a delay in pulling off the data. So that is why unfortunately some of our dashboards are not complete this month. It is being rectified as we speak, but there is a significant delay in pulling off the data. But and I think the difference is in maternity there's an awful lot of data that we do have to get off. So so apologies about that. Changes in our senior team. So for those of you who know Jane Lovedale, she's been with the trust, I think I want to say nearly 40 years, and she is retiring. She's returning, but it did mean that her post was available or was going to be needed refilling, and we have now appointed Karen Green, who is now our clinical quality and governance senior midwifery matron. Right, mouthful, but she is Jane, in other words, but it is very much a matron post. Again, we're really trying in maternity or midwifery to look at the real safety and quality aspect, and that's why it's now a matron post. And also I'm very happy because we've now appointed a deputy head of midwifery, who I have confirmed is starting the end of July. So that will be really good, and as soon as she's starting, obviously as an induction, she will come and meet you all, so that's fantastic. And then really just to give you a bit of background, so as part of Ockenden, it's really important that the perinatal surveillance tool, and it's really for the trust board to or people at trust level to have a real oversight of the quality in maternity services. So there are going to be some standing items in this report just to give you that quality oversight. So obviously we have our quality dashboard, which is attached. We also have the safety champion walkabout feedback. Also, I've put on there the staff satisfaction survey results, our survey user feedback as well. So it's just giving you that real oversight of the whole quality of the maternity services. Only because I was on, obviously, your meeting earlier, I heard that Steve gave an oversight of the CQC visit that happened in earlier on this month, and we are just awaiting for the final report. We are submitting lots of data, and Sue and I have had a fair few phone calls with the CQC, just clarifying a few things, but we are hoping maybe in the next, by the end of May, we should have the full report. And that is a really quick overview of the paper. I'm happy to answer any questions.
Thank you, Karen, and it's a comprehensive paper, and thank you for the overview. Can I ask just one question? I'm very conscious of how much has been thrown at maternity services in the last few months, never mind, you know, in previous years. And you've been running without a deputy, you've been running without some key personnel. How is the team? Because actually it's tough for you, very tough for you as the leader, but it's pretty tough on the team too.
Yeah, and I think it's safe to say it has been pretty much since I've come in post, it has been pretty rubbish for many things. And I think, you know, no one comes to work thinking that they're doing a bad job. Everyone comes to work because they want to do the absolute best and they want to give the best care. And I think having the CQC warning and the CQC report, it did take its toll on staff. And then you have COVID and everything else that goes with that, and resilience. It has taken its toll. And I know that we have accessed the wellbeing service more than any other division. So I know that we are trying to get help for our staff. But having that little bit of positive feedback from the CQC has been absolutely amazing. It's given everybody a real upbeat. It feels different. I can hear laughter. So that is really great. And that was on the back of eCare, and that was pretty shocking 2 weeks as well, I have to say. But you know, we got there. So yes. So we know we're on a journey. We know we're not perfect, and we've got lots still to do. But the staff are definitely it feels better.
Good. And tell us if there's more we can do.
Yes, absolutely. And I think from the first time ever, we are actually employing more staff than we're losing. But that is national picture. That's not just here at the West Suffolk. That's a national picture that midwives are leaving the profession in high numbers.
Yeah. Karen, just as long as you don't. Thank you. Thank you ever so much. Are there any questions for Karen? I mean, we've had your report. It's pretty comprehensive, and I think you know that you have the board's absolute support and thanks. And please feed that back to your team because they are working their socks off. So thank you. Okay, I'm going to move on. Can we move then, please, to infection control next? Sue?
Yes, thank you, Sheila. And you'll be becoming familiar with this report. I'm sure it's an update from the ones we previously presented. So really, just to note that we continue to monitor our IPC guidance, make sure that our BAF is up to date. We have recently undertaken a full gap analysis from where we've received information from HSE inspections relating to COVID and infection prevention control. So we are capturing that data and sort of self-assessing ourselves as to where we sit with that regards to that. As has already been alluded to, at this moment in time, we do have no positive COVID patients in the organisation. That said, we are not relaxing. We are absolutely still on high alert and monitoring every single patient that comes through our organisation, because we do know that it is still out there in the community. So it's really important to keep reminding staff, all staff and visitors, to follow our PPE guidance. I'll leave the rest of it to be taken as read. The only thing to update you on, as you may or may not know, we've been managing without a lead IPC nurse since August last year. The team have been phenomenal in supporting and guiding us through the latest wave of the pandemic, and they have done that really brilliantly. I have been out to advert again for a lead IPC nurse, and I'm hopeful that I will be able to recruit from this part of the recruitment, this wave of recruitment. We do know, a bit like midwifery, infection prevention control nurses are fairly rare, and I do know that they're struggling to recruit into the ICS as well. So I'm hopeful that this time round we'll be successful, but I'll update you next month.
Okay, thank you, Sue.
Great questions.
Alan?
Absolutely. On IPC, with the learning from the pandemic, is there a specific IPC work stream feeding into the new hospital building?
Yeah, so the infection prevention control team are working very closely with Mark, and they absolutely are very much engaged in that process. So there will definitely be, and you know, things like, we know that our limitations in this organisation, for example, are the number of single rooms, the number of ensuite facilities, the inability to have doors even when we have got single rooms. It's the air control and the airflow that we have through them. So all of that is being built into the new systems. Yes.
Right. Thank you.
Thank you very much indeed. I don't think I have any further questions. Thank you for a very comprehensive report, Sue. And we'll keep our fingers crossed that you have some positive news on the infection control lead next time.
Yes, and just to put on the radar, we are now sending out our letters of duty of candour for our nosocomial infections. We are completing our root cause analysis for the outbreaks. So I do anticipate some feedback from that from patients and relatives going forward. I've had a couple, but there will be, I suspect, not just within our organisation but across the country, a lot of interest in that.
Yes, there's been quite a lot talked about nationally, hasn't there? So yes, I anticipate there will be. If we could move to the nurse staffing report then, please. And is Dan taking that, Sue?
Yes, please.
Okay, over to you, Dan. Welcome.
Thank you very much, everybody, and good morning. So I will take the paper as read, as standard, picking out some of the highlights for the month of March. Overall trust fill rates continue to be positive with RN rates, and that coincides with our falling sickness rate. That we've observed over the last month. Coupled with that, our nursing quality indicators have improved month on month, again further illustrating that link with inpatient safety. Particularly around vacancies, our RN vacancies do remain static around 9%. For the areas described in the paper, there are some areas of individual concern which you see in the appendix, and we're working with them closely to further improve their recruitment plans, to support them in that recruitment plans. For example, F6, you'll notice in the appendix, has got quite a high vacancy rate, so we're working with those teams and doing bespoke adverts for them to try and attract nurses to that speciality. NA vacancies, so nursing assistant vacancies, have improved month on month. It's gone from 7% to around 4%. This is a reflection of the work that has been completed with NHSI and the region around trying to reduce our NA vacancies to 0 by April. While I don't expect us to be at 0, 4% is a very healthy position to be in, and that will further improve and when we see our April stats, because we have reduced some of our establishments for nursing assistants. You will have seen in Karen's report as well that supernumerary status of our labour coordinators, which is something I allude to in this report, has also continued to improve, which is positive, and I'll take any further questions.
Thank you very much indeed, Dan. Right, could I have, I've got David, Rosemary and Angus. David.
Hi, Dan. The joint Glastonbury Court Rosemary Ward the monthly business unit meeting a couple of weeks ago, which was quite useful and obviously is quite important in terms of triangulation of assurance and stuff. Looking at Rosemary Ward, that became effectively a COVID recovery sort of focus, discharging patients to there, and at the same time we increased the number of beds to 33. And the staff were explaining that actually because of that there was a lot more pressure and in terms of acuity of patients and everything else. And I think they've struggled really to recruit people, not only numbers, but staff with the appropriate skills, etc., that are required for that type of patient cohort. I understand you've been working with them on the sort of safer nursing tool as well. But in that sort of context, I wonder if you could tell us how we're ensuring that patient safety is managed, where we've got an increase in acuity, increase in beds, and possibly a sort of shortage of suitably qualified or trained staff available.
Yeah, of course. Yes, Rosemary Ward has been an area of specific focus over the last month, particularly noting their change in demographic, both increasing their patient bed base, but also the number of Pathway 1 patients are going directly home as opposed to going to Rosemary. So the number of the more dependent patients are coming, so the number of higher dependency patient has increased, if you like. We are currently working with Rosemary Ward to relook at that acuity and establishment based on that change in demographic, and we've put a number of actions together to support them in that journey. And there is actually today has come through into my inbox is a review of that staffing, so I'll be reviewing that with the team to see how that fits with their new structure or their new plan. I guess the other thing to say is that we are actively supporting them within the acute day on day, when their acuity is higher than, or dependency is higher than anticipated against their nursing staffing. Something that I'll feature in my next month board report is the reinvigoration of our safe care module within Health Roster, which gives us a real-time risk assessment of all of our wards areas, including Rosemary and Glastonbury, and we're starting to use that to mitigate risk across the organisation from a much more pragmatic approach as opposed to a finger in the air and feeling, which is often accurate, but this is going to give us robust assurance around where that risk places, not just within Rosemary, but also within all of our wards.
Yeah. Okay. Thank you very much.
Thank you, David. Rosemary?
Thanks. Good morning, Dan. I just wondered how you monitor and analyse data on retention of new starters, and what is the retention rate? And can you give assurance that you build that sort of attrition rate into your figures for new recruits?
So that level of data isn't easy to find at the moment, but I'm currently working with Claire Sorensen, Deputy Director of HR, to look at a nurse recruitment pipeline, but also looking at attrition. Certainly from an ad hoc point of view, we've certainly seen that attrition of new and nursing assistants does seem to reasonably high, although I can't put a nominal data on it. So we have got additional resource, again, following the work with NHSI around pastorally supporting these new staff. Certainly in March, we saw double the numbers we normally do of NA starting, and Sue and I often meet our new recruits on their first day of induction, and we're seeing a lot of people coming that haven't been in healthcare before. And I often think that might be a symptom of people wanting to do something with the NHS following the pandemic. But sometimes healthcare isn't what they anticipate it to be. So we have got 2 new staff within our education team to support those pastorally and get them through their care certificate in a timely fashion, so that we do recognise that their attrition is there. But in regards to retention and turnover, if you like, of new starters, I don't have that data to hand, but I'll be working with Claire to build that into our paper, if that's something of interest.
Thank you.
Well, of course, it's of interest.
Thank you, Dan. I've got Angus, Helen and Alan, and then I am going to wind up and move on. So, Helen, oh, okay, Helen.
Thanks, Sheila. Mine was just a point of clarity, which I do think is quite important. We may have physically created the space for 33 beds at Newmarket. We have never opened them to 33 beds because we were always mindful of their staffing deficits. And as part of what the work that we've just been doing, we've maintained them at their previous bed numbers, and we're working on a plan, which is what Dan's just alluded to slowly increase them, probably by August, to 33 beds.
Thank you for that, Helen. Alan and Angus, you've reappeared. Angus, you were in there before, Alan, so I will take you first if you would like to come in.
Thank you. Sorry, I'm so paranoid about my legacy hand. I pulled it down too quickly there. Apologies. I think, Dan, you've touched on this in your answer to Rosie, but I was reflecting on, if we look forward in 12 months' time at the recruitment market that we're operating in, how different it might be to what we're currently in. And you alluded to your pipeline of plans, and I just thought it'd be helpful if we could add some more colour to that, maybe in some future reports, to show that we're anticipating that the world is probably likely to change a bit, I would imagine.
Alan, was yours anywhere a similar question? I'm just wondering whether to pick up both.
No, a bit different.
Okay, can we pick up that one then, please, Dan? We've lost Daniel.
Sorry, I didn't get Alan's question.
Sorry, Angus. Can you ask the question again?
Oh no, I think we acknowledged Angus's request. We'll put the pipeline within the name.
Okay, that's fine.
Perfect.
I didn't see
Thank
the
you.
acknowledgement.
Sorry.
That's fine. I just wanted to check we closed that one off before I got to Alan. Thank you, Alan.
Dan, is there a version of the Safer Staffing tool that can be used for our kind of field force in the community beyond Glastonbury and Newmarket and so on, the actual field force of nurses out there? Is there a version of the tool that can support them?
There is one being developed nationally, but it's yet to be accredited or endorsed by NICE like the other safety nursing care tool. But it's coming, allegedly. I don't know how soon it's coming, but the current community teams are working with a capacity and demand model at the moment. That work is ongoing. to look at what their staffing needs are, but so it's not completed yet. So the community teams are doing something. They're not in regards to managing staffing a need or reviewing staffing need, but it won't look like the Safer Nursing Care tool yet.
Okay, thank you. We'll wait for that.
Thank you, and thank you, Daniel, for your report. I mean, it does feel as if we have so much better understanding of our staffing and any issues around staffing than perhaps we have in the past. So that's really helpful to have that and to understand the detail. I'm going to move on at that point. Improvement Programme Board report. You've got it before you. Sue, is there anything you want to highlight?
No, I'll take it as read. There's the extensive improvement plan is appended to this. I think just to point out that this was following on from the last improvement board, and as of next month, many of you are aware, we'll be moving to the new 3I structure, which is improvement, insight and involvement. And so just to assure you that any of the outstanding actions on this plan that are required to be delivered will be transcribed across to the relevant committee to keep monitoring and the progress on that. Through the insight, improvement and involvement committees, we are hoping to use, certainly for the improvement committee, the PSERV priorities as our sort of baseline and structure. And also what I really would like to do is sort of, we're going to be, while we will still be focusing on the requirement to meet the CQC regulatory requirements, what we want to do is move towards the language of using a trust improvement plan for improving quality and safety for our patients, because that's the right thing to do, and really focus on that so we can help our staff to be looking for the future rather than in the past.
Thank you, Sue. And I think we should say our thanks to those who have established the improvement board on a very firm footing, and that can help underpin the work of the new committee moving forward. And it's important as we move from one system to another, we don't lose things, and we don't we try not to duplicate. There's enough for everybody to do, but I think it's done some amazing work, the improvement board, and so you've had a very big hand in making it a successful committee. So thank you.
Thank you. It's been very much.
So you will have a hand in making the next one successful as well. Okay. Can we then move on, please? And we'll move from issues to do with patient care to the more prosaic car parking tariffs. Craig, over to you.
Thanks, Sheila. It's everybody's favourite topic, isn't it? So what you've got in front of you is purely an extension of broadly what we're doing at the moment, but it's just to confirm that our position is in line with government guidance. Yeah. Guidance does continue to be updated, and our commitment is to always follow whatever that guidance changes to. But there isn't a significant change that's flagged here. It is a continuation of what we're doing, and it's subject to change. So the current guidance is basically designed to last through the duration of the pandemic. It's obviously unclear what the end point of that is, but we would expect a change in the guidance when the end is reached. So nothing else I was going to add. Happy to answer any questions, if any.
Thank you, Craig. Are you happy to note the report? There's nothing significant here, and it's very self-explanatory. Is everybody happy? I'm taking silence as yes. Steve, you've got your hand up.
So I love the responses that are in the paper, and it might be something we take offline just in terms of how we communicate the thinking for, in a sense, post-pandemic on some of this. But let's take that offline. But it's a very good paper.
Okay, thank you very much indeed. Okay, thank you very much indeed. Can we move then to Future Systems Board report? And Craig, it's you again.
Thanks again, Sheila. So what you've got here is details of the activity of the Future System Programme team over the last month. Again, I think most of it is self-explanatory. What The only thing I would choose to highlight, and it probably picks up on Joe's question to Kate from earlier, the meeting we had with the Construction Industry Council around the 46 different aspects of the planned new facility was a really good session that we had there. And one of the aspects that we did consider at length was around sustainability and the need to meet the government's net zero carbon targets. We are absolutely committed to delivering a sustainable development, and that's in its widest sense, from the procurement of materials to the design of the unit, and the integration of technology into the future system programme, and how that can impact on the carbon emissions. So another really busy month. We are expecting at any moment now an indication from the Department of Health as to in terms of a formal response to the deep dive meeting we had with them around the stage of the process that we are at. As it mentions in the paper, we had some really good informal feedback after that meeting, and it's clear that we've progressed well through the process in comparison to other projects. So we continue to push really quickly for the reasons we've discussed in previous meetings, and indeed the response I gave to David earlier around restricting capital investment into our current facility because of the move into a new facility. The sooner we move into a new facility, the better the position will be, and that's our only chance of minimising expenditure in a way that would be wasted. So lots going on, lots of really good progress, really, really exciting project, and I think being done in the right way.
Thank you, Craig. And I we've talked about teams today. I think the team that are working on this have made a phenomenal amount of progress, and been inspirational in the co-production and in the breadth of thinking. This does feel different to any other scheme I've been involved with in the past. And I thought the Dumfries and Galloway stuff was particularly interesting. And Jeremy, I noticed you commented in it on the chat. I think we don't think enough about healthcare and environment, but I won't wax lyrical on that one. Is there any questions or comments, Rosemary?
Thanks. Good morning, Craig. Just a quick question, and forgive me if I might have sort of asked this in a different way before, so forgive me. Just on the digital agenda, am I right in thinking that the digital capital costs are not included in the overall project plan and will be separate? And if that's the case, if my memory does serve me correctly, will that come out of the trust capital budget in the forthcoming sort of few years?
So the assumption at the moment is that we will include £20 million for digital capital in the final scheme.
Right.
It's unclear as to what the split will be, what they're expecting to be in the OBC and what would be outside of it. Obviously, we're more advanced than most other organisations, and there is an attempt to get a degree of comparability. I should have said on the digital stuff, so we've just completed, so at the end of last week, we completed a sort of immersive digital fortnight where we took a number of in particular clinical leaders from across the organisation through a hothouse exercise around the potential for technology to improve the future system programme. And one of the key things within that was around aspects of digital exclusion. So there are significant significant numbers of people within the population that are excluded from technology, and they represent a disproportionate amount of our patient population. So people who are excluded have a greater chance of being admitted to hospital or being treated in the community, and so that remains a significant focus. But at the moment, we are treating the investment in technology somewhat separately, but it will be rolled into the final figure.
Okay. And can I just say that the work that you and the team have done is outstanding on the future system. It's really very impressive.
Thanks, Rosie.
Some of the best I've seen, so thank you.
Thank you, Rosie. Right, if there's no other questions or comments, I think we should note the progress, but note it with great enthusiasm and warmth. Okay, so thank you all very much, and thanks to your Future Systems team, because they are doing phenomenal work. If we could move on to the governance report then, and Richard.
Thanks, Sheila. I'll take the report as read. The one element I was going to just call out, and Sue's alluded to it already in terms of the 3I structure. It's been quite well rehearsed in terms of the change, but it's the result of a co-production piece of work with leaders in the organisation, and reflects a desire for the board to work different, and I think will allow the board to work very differently. We're starting to see some of that today, I think, in terms of the agenda of the discussion. But it is a new structure which will evolve over the coming months, a new way of working. But I'm grateful for board approval to put this change into place, but very much recognising a planned review of effectiveness during the year. So I have to take any other questions on the report as well.
Thank you, Richard. And I think, we've spent a long time talking about this. I think it's really, really exciting. It gives us a huge opportunity to work in a different way, to be more open, more inclusive, more strategic. And those are all things that we need to do, and we've been encouraged to do by so many people. And we know that that's a good thing. But I think the most important thing of all for me, Richard, is we've built in an evaluation process from the beginning. Too often, organisations start on initiatives and don't review it as they go along, because undoubtedly there will be impacts which are intended and there will be impacts which are unintended. They may be good, they may not be so good. So we need to make sure we do that as we progress through the development period. So thank you for that. Is there anything else from Richard's report anybody wants to highlight before I get to the recommendations? So note the contents of the report, and are you happy to approve the new framework for engagement and oversight? Okay, I'm taking that as yes, no hands up. Thank you very much indeed, Richard. Can we come to the last bit of the agenda then? I haven't been brought any items of any other business. In that case, thank you. Date of next meeting will be the 28th of May. Richard, we will still be working like this, won't we? And probably in June as well. So thank you. We will see you back on screen at the end of May. I'm proposing we've got, I think, 15 minutes exactly, haven't we, Richard?
That's right, yes.
Thank you. Can I say, I would appreciate any feedback on today's meeting, because we have spent a lot of time on individual presentations. So we've had more access of people to the board and more opportunity for people to come to the board and present. It's something we've committed to doing, but I always appreciate feedback about how we do it. So I will see the members of the board back in 15 minutes. I'll give you an opportunity to stretch your limbs briefly. Thank you. And thank you to all those people who've attended. Very much appreciate how many of you give up the full 3 hours to be with us. Thank you.